In this video, we'll discuss about the vertical jaw relation. So, the definition of vertical jaw relation is that it is the establishment of a vertical dimension of denture in harmony with the face for maximum functional efficiency and patient comfort. Basically, in layman terms, vertical jaw relation is the distance between maxillary and mandibular cast. Now, in this, arbitrarily, 2 points are marked, one fixed, one movable, or one above the mouth and one below mouth. And the distance between them is calculated in occlusion and resting stages. Now, in vertical jaw relation, we have two aspects. One is vertical dimension of occlusion and vertical dimension at rest. Now, vertical dimension of occlusion is when both the upper and the lower membrane or the lower members are touching each other, and vertical dimension at rest when they're not touching each other, that is when they're at rest. Now, in vertical dimension at rest, there is very important term which is physiological rest position. Now, physiological rest position is the position of teeth when the patient is upright and relaxed and the muscles associated are in a state of minimal contractual position. All right. Now, suppose these are our two occlusal rims, and another case scenario is this. Now, when the rims are in close contact like this, it is vertical dimension at occlusion, and when they are spaced, it is vertical dimension at rest. Now, the space that exists between the both the maxillary and mandibular rims is called as vertical jaw relation or the vertical dimension of the denture. Now, there is a space in VDR, but there is no space in video. This space, the difference between the spaces, is called as freeway space, and it should be 2 to 3 mm. All right. Then coming on to the what if the vertical dimension is increased and what if vertical dimension is increased or decreased. So in vertical dimension, if it is increased, first of all there is risk of trauma to the tooth. There will be a clicking sound on biting, discomfort to patient. There will be pain in basal area or basal seat area of denture, loss of freeway space. Then patient will have an elongated appearance. Muscles, they will have contracted state, so there will be muscle fatigue. Then there is going to be bone resorption. Then loss of retention and stability. Now, if the vertical dimension is decreased, this is very important. Now, in this, what you will see is there is going to be reduced masticatory function, cheek biting, then poor aesthetics. Then the patient will have the classic denture look. Very important manifestation of decreased vertical dimension to remember is angular cheilitis. Then there can be Coston syndrome. Then prognathism. Then loss of tonicity of face, of facial muscles. The face will appear flabby. and loss of lip fullness. So denture look will be seen in decreased vertical dimension. Now, one more thing, the freeway space is also called as interocclusal distance. It will be VDR. This is, since this is bigger, minus VDO. All right, and it should be 2 to 3 mm. Now, coming on to the methods that are used to record the vertical jaw relation. So there are two methods. One are the mechanical methods, and the second one is the physiological method. Now, in mechanical methods, first we have is ridge relation. In this, the first point is the distance between the incisive papilla and mandibular anteriors. Now, you must remember that the distance between incisive papilla and mandibular anterior should be 4 mm at centric occlusion. Now, why we use incisive papilla is because it serves as a stable landmark and there are hardly much of the changes with the age of the person. Then, second, ridge relation. In ridge relation method, we have parallelism of ridges. Now, parallelism of ridges. Now, since the when we do the dentures. Now there is a need to provide a 5-degree opening in the posterior region to provide parallelism of the ridges. All right. Now the second mechanical method is former dentures. Now former dentures can give us a record of the person's habits, the rate of residual ridge resorption, all right, and the wear of the teeth. Then is pre-extraction record, very important. In this, we ask for patients' pre-extraction radiographs. Then we can ask for photographs. We basically enlarge the photograph and then we give similar anatomical landmarks on the photograph and the person, and then we analyze the vertical dimension and the occlusal height. All right. Then we can also go in for profile silhouettes. In this, what we do is before extracting the teeth of the patient, we take a cardboard and we make a marking with the wire contouring to the facial profile of the patient, and then this cardboard, and then second, after post extraction, we make again one more cardboard and then we compare both the vertical dimensions. So profile silhouettes, then profile photographs, radiographs. Then we can also take the opinion of the relatives, parents and children. All right. Then facial measurements. Yes, in this facial measurements, basically we use tattoo marks. We will make one tattoo mark above the mouth and the another one below the mouth, and then we will ask the patient, and we will compare both the cases. Now coming on to the physiological methods which are most commonly employed. Now in physiological method, the first method that is very much in use is the physiological rest position method, or we can call it as Niswanger's method. In this, what we do is, first of all, we will insert the maxillary rim. All right. Then we will ask the patient to basically rest. Um, we will ask the patient to rest, and then we will record the VDR. All right. Then we will contour the mandibular rim and we will insert the mandibular rim into the mouth of the patient. Now, the mandibular rim, we have to contour the mandibular rim in such a way that we get a freeway space of 2 to 3 mm only. So this is the Niswanger's method. Then the second method that is used is the swallowing function record method, swallowing or pattern record method. In this, what we do is we take a cone and we add the cone to the mandibular rim. Now in the mandibular rim, when the patient swallows, so the height of the rim decreases. We heat the cone and then we tell the patient to swallow, and then the height decreases, so we can calculate the vertical dimension accordingly. All right. Then in the third method is the phonetics and aesthetics as a guide. Phonetics and aesthetics as guide. Now in phonetics, we talk about the Silverman's closest speaking space. Now, Earl H. Pound, or Earl Pound, Dr. Earl Pound, he told that the maximum distance should not be less than or more than 2 mm in anteriors when person pronounces the alphabet S. All right. If there is a lot of space in the, then the pronunciation will be different. And aesthetics, if the vertical dimension is more, then as we talked about in here, the vertical dimension being more, so there is going to be if it is less, there is going to be loss of lip fullness. All right. Then a neuromuscular proprioception, very important. Neuromuscular proprioception. In this, what we do is we use a central bearing device, proprioception. and a central bearing screw. We attach the central bearing screw first and then the central bearing plate. Then we calculate. Then we see how the perception of the patient. Then another method of recording the physiological vertical dimension is through biting force, that is power point, or bimeter, maximum biting force. In this, we calculate the force that occurs when the person bites with the use of a biometer. All right, so this is the vertical jaw relation. In the next video, I'll be making on horizontal jaw relation. I hope I made it easier for you to understand. Do like, subscribe to my channel. Thanks for watching.